Thank you very much for the invitation and the opportunity to speak. So we're going to transition a little bit away from MESH now and kind of talk about the ERAS pathway and more specifically the medications. I have no disclosures. And this is the ERAS tour, right? She stole our word, I think. We were using it before she was. But I think very fitting since there is now a new album out this week. And so the eras of the ERAS, there's the pre-op, there's the intra-op, and there's the post-op. And there is really a lot that goes into this, more so than just medications. But what I'm going to focus on in this talk is really the medications that I use in my practice and go over a little bit of the literature of why. So this is our current standard of what we do preoperatively, intraoperatively, and postoperatively for our abdominal wall reconstruction patients. So preoperatively, we use avalominopam, 12 milligrams. We use Tylenol, we use gabapentin, of course, heparin, and Ansef. So talking about gabapentin obviously is a neuropathic pain medication that has been shown to decrease the amount of opioids that need to be used if you use it preoperatively. As you saw, I also do continue this postoperatively at a scheduled basis. There is a lot of research out there showing that this does decrease the amount of morphine equivalents that you will need for your patients. It decreases that pain receptor pathway and the need for the opioids. Looking at acetaminophen, one of the easiest things that we can give our patients. I think a lot of this is also patient education. A lot of my patients are like, oh, Tylenol never works for me. Acetaminophen doesn't work. It really works when you combine it with these other medications, when you combine it with the gabapentin as well as with NSAIDs. And now we look at our antibiotics. Assuming this is a clean case, we use Ansef as our antibiotic of choice. And there's been some evidence to show that that is the best to decrease our mesh infection rate, our wound complication rate. But the reality is so many patients come in with a quote unquote penicillin allergy. What does that mean? And what is the chances of them actually having a real allergy is actually quite rare. So we have an algorithm for this. This is quite small and not really meant for you to read, but the reality is if the patient's reaction was more than 10 years ago and it wasn't anaphylaxis, it's very unlikely that they actually have will have a reaction to Ansef. So we risk stratify them, and assuming that they are minimal or low risk, we do give them Ansef and continue with that to try to keep our infection rate down. So intraoperatively, what can we do while we're in the operating room? We use a lidocaine drip, assuming the patient has no cardiac contraindications to this. We start that on induction when they get into the operating room and continue it until we do our tap block, and we stop it when we do our tap block. So talking a bit more about that is it actually modulates the pain pathway, and it leads to anti-inflammatory effects, which allow you to use less narcotics both in the operating room as well as post-operatively. And allowing us to, as we know, that using less opioids will allow us to have quicker restoration of our bowel function, keeping our length of stay down, getting our patients up and moving and back to their regular activities as quickly as we can. So a tap block, you can, I think, do this in many ways. We are very often staring directly at the plane that we need to be to do this. You can do this yourself open. You can do it laparoscopically as well. If I have the ability, I use liposomal bupivacaine. You can also use regular bupivacaine mixed with saline and do 60 cc's on each side under direct visualization. Like I mentioned, we stop the lidocaine drip when we go to start this. So what does this do for you? It really decreases your length of stay. That is really the biggest thing. And we're able to decrease our length of stay when you compare this with an epidural, which was done by Dr. Cabrinel's group. And then again, we're looking at morphine equivalent and decreasing how much opioids we're using. We know is good for our patients. We know we want to use opioids as least as we can. And we know we want to decrease that length of stay for our patients, get them back to their lives and improve their quality of life, because that's really our whole goal with this. Then looking at postoperative urinary retention, the use of Sugammadex as a reversal agent has been shown to significantly decrease our postoperative urinary retention. Again, for simple our small outpatient procedures. We want these patients out of the PACU. We want them to go home. We don't want them to have to come back. So if we can decrease our urinary retention rate, that is going to be good for our patients. Then post-operatively, you can see it's really a multimodal approach. And we use all of these things. Of course, there are certain patients that can't have certain medications and you have to adapt everything. The one thing that I do preemptively adapt is for all my geriatric patients, I use a lower dose of gabapentin. I find that the other side of that is that they feel very tired and sleepy, and they or feel foggy, as some of my patients will say. And what this does is prohibits them from getting up and out of bed and getting their bowels moving and walking in the hallway, and that kind of I think is detrimental to what we're actually trying to do with an ERAS protocol. So again, looking at avolinopam, we give this 1 dose preoperatively. So you saw it in the pre-op and post-op area. And we do this, again, for our hernias. But this is obviously a colorectal study. When they looked at it, they're doing anastomotic cases. And they're able to show that the post-operative ileus rate is decreased, as well as, again, that length of stay. Doing this for hernia patients has a similar effect, even if you are not doing an anastomotic case. And this is looking at the cost, because let's be real, that's what the hospital cares about. The medication is more expensive and they do not want you to use it. But if you put everything together, the cost actually is no different or lower. And that is most likely because of length of stay. So again, as I mentioned, this has also been shown in hernia. And again, I think I keep saying the same thing, but it's really length of stay and really back to the patient's quality of life, right? Nobody wants to be in the hospital, and they want to get home. They want to get back to their regular lives. So getting them home in a safe manner, decreasing your length of stay if your recurrence or your readmission rate is super high is not helpful. We want to get our patients home safely and back to what they want to do. So again, I think this is not a new concept. Dr. Nowicki showed this in 2016. This is not really anything novel, I think, but it all kind of makes sense. If we have a multimodal approach with our medications, we really can improve our patients' outcomes. And then on discharge, it's not done yet. So we actually use how many morphine equivalents patients are getting while they're in the hospital to then discharge them with their opioids. So depending on how many they've gotten in the last 24 hours, we therefore then give that prescription based on that. Again, I think it's important to recognize the postoperative period does not end when they go home. And so we want to keep making sure that these patients are have their pain controlled, that they're getting back to their regular lives. And thank you. That was the ERAS tour.